Uh, so a little bit about Bill's Global Foundation and about me. I'm a cardiologist, and I'm here in the Yardley area, which is a suburb of Philadelphia, medical graduate of 1968 from Baroda. And I'm here, you can say, for 51 years. So I'm a Philadelphian. I went to UPenn for my training for 5 years and started practice. And I'm still practicing, although I stopped going to the hospital last couple of years, just see patients twice a week. The So I bring in the healthcare in Wills Global. So as you will see that Wills Global, we have people from 2 or 3 organizations in different sectors and very similarity that we have. So Wills Global Foundation, a word about it, which was organized in USA and in India. So we have Wills Global USA, Wills Global India. And this is by visionaries, technocrats. And it's not just for IIT, IITians, but also non-IITian like me, who have joined because of its very worthy, noble mission. In the background, this was Pan IIT Global Meet in Bombay in 2006. Keynote speaker by President Abdul Kalam then really inspired IITians to and asked them to use their technology knowledge to solve rural India's problem. What are the particular 5 rural India's problems that we have is water, healthcare, energy, education, livelihoods, and sustainability. Livelihood to create jobs and not only that, but everything to be sustained in all these vectors. So this is, and so if you take the first letter of each one and make that acronym, that stands for WILS. WILS stands for water, healthcare, education, energy, livelihood, and sustainability. So this is who the WGF is, and this is what their mission is. It is not only it not only a NGO, but it's an NGO by Niti Aayog, which is our Planning Commission of India, has recognized for innovation and technology transfer. So this is who we are. Now, how are we? I mean, we have so many NGOs, we have so many organizations, and each one brings a unique perspective and the unique mission that is dear to their hearts. We have one guiding principle is that anything that is done is a technology-driven solution. So, and it is not a funding organization. The donations it receives, it actually, they use that to find a technology solution. And that solution then have to be self-supporting and sustainable. So that is something unique about it. Second thing, all the board members, including Rajat Gupta, ex-CEO of McKinsey, to 99% are IIT alumni. And they are literally who's who in the world, from Microsoft and Google down to anything you can think of. There is an IITian. And they're not just in the technology, but they're also in India. It turns out 60% of secretaries and those who real executive branch who runs our country, they are IIT graduates. So it's really amazing what this very, very smart. I mean, if you are an IIT admission you get, you have to be the cream of the crop. And then those who graduate and this, they have changed the world. So if I, and they have led the revolutions in every area, not just the technology or engineering, but also in medicine, because 90% of medicine that is practiced is technology driven. Everything that we do, other than talking to the patient, is something which is created and sustained by technologists. The board members, they do not take salary. It's all completely voluntary. If anything, each one of us, each board member contributes to sustain the organization and provide the funding. So, and of course, we get general support from other people. So this is all about Wills Global. Now, the workings of the Wills Global. So as I showed you the five sectors, today we are going to talk about on the healthcare sector. And in the healthcare, we have, our focus is to provide access to affordable healthcare. Now, why we choose that focus? First of all, Wills doesn't have the funding or the bandwidth to open the free care or supply or provide the means, etc. So we are limited in that area, but we have the talent and time of some of the best technologists who can help us to take a problem. And the problem, when you look at the rural America, rural India, where 800 million people live, they do not have access to the healthcare. There are primary health centers, but they are in, for every 30,000 population, there is one center in India, but only 30% have even doctors. 70% are just the building. And they're usually several kilometers away from where the patient lives. So what can we do to bring the healthcare at the doorstep of that villager or of that rural person? We can't build every hospital. It will be an ideal village to have nice housing, affordable housing, water supply, electricity, education, schools and colleges, hospitals and clinics and pharmacies. But that smart village, we have started doing work. We're going to have this conference on smart village. Everybody is doing something to make that happen. But when that happens, it's a tall order and we have a long way to go. So at least for now, we can focus on one thing, and we have focused on how we cannot build clinics and hospitals and bring the doctors in the villages, but we can at least have a means of providing access to the healthcare. Now, how can we do that? And that's where the magic of technology comes. And we use technology of telecommunication, televisits to provide that care. And that's what we have done. Now, obviously, for last 2,000 years, since the days of Hippocrates, medical care is always delivered in person. You either go to the doctor or doctor comes to you. It's always in person. Now, the concept that we can do this remotely started 100 years ago with telephone. And we are actually talking to the patient and provide some care. In last 20 years, we have a better technology development where we can now not just talk to the patient, but we actually see the patient. And now you can see I'm reaching out to people from East Coast to West Coast and everyone using our technology. We can see face to face and listen. So the same thing we started using in telemedicine when it became cost effective to be able to do that. Obviously, that has been my passion since I was doing my fellowship at Penn in 1972. Of course, we only had at that time was telephone, and we are using telephone to monitor pacemaker. And that was the kind of a idea. Why can't I just see the patient and listen to the patient? We were able to do cardiogram. Why can't I listen and do the physical exam? But of course, I won't go into the detail. It took me about next 30 years to come to find out by trial and error what works and what doesn't work. And finally, when internet came, World Wide Web became available in 95. That's the time I was doing my MBA. That was my thesis was how I can leverage it. And that's where the concept of telemedicine in my thinking came around. And I was the first in America to have a freestanding telemedicine clinic into Walmart stores from 2012 to 2014 in Philadelphia area. And I saw more than 1,000 patients, presented the data, and got the first prize at American Telemedicine Association. So this whole telemedicine, of course, I'm not a technologist, but I have understood what technologies can do for me to bring about what I want to do to deliver healthcare. And that's a passion I bring in. So we created using telemedicine, we created a program, we call it Healthcare Easy Access for Rural Community via Telemedicine. So if you take this first letter, acronym HEART, so we came up with the concept of heart centers. And this is a very rapidly scalable force multiplier solution. And I'll go over and show it to you how that can happen. And this really empowers the rural community to sustain and grow and do social development projects. The way it works, since, as I said, we do not have the funding for ongoing support and this. So we believe that we give one-time donation to, we use $1,000 to create one center, which will serve about 3,000 villages, which could be a cluster of villages within walking distance, like a 1 or 2 kilometers. And this center, we use $1,000 to give them the hardware, smartphone and other devices, and I'll show it to you in the next slide.
Raj, one correction, okay? It's 3,000 people in the villages, no, not villages.
To serve 3,000 plus villagers.
Villagers, yes.
Yeah. That's what I say. 3,000 villagers. Yeah. So it could be in one village or cluster of village, but we need this population to make it self-sustaining, and I'll go over that. And there we give one time $1,000, and that buys us the hardware. Now, the software and support, we charge a small fee, and I'll show you next slide. Now, the beauty of this is we do not have somebody go to their village or this. We actually take the two villagers, resident of those that village, that rural community, one male and one female, and train them to be a telemedicine operator, or we call sahayak or helper. So, and they get earned their salary from doing the visits, and I'll show you that. And then, of course, we don't have wheels itself from here. We don't have feet on the ground at the villages. So we collaborate with local organization, and we will be happy to collaborate like SAI organization or any other organization. We are already talking to two other organizations. One is Indus US, Indo-US Setu, Tandon Sisters, who are operating mobile vans in Uttar Pradesh. We are collaborating with RDT Foundation. We are collaborating with other NGOs, but they are the one with whom we collaborate, and they are actually there to coordinate and supervise the project. And the technology part, we partner with Evolco's HR. They are our technology partner, very well grounded, excellent software and support system with about 300 employee who actually go to the village, train the people hands-on and support, and that's our technology. And then, of course, we will monitor and measure the impact and matrix. Now, the next. So here is the center. So this, the way center called TeleMedicine Heart Center, the way it is, resident of the village, one male, one female, they are given the devices. Everything works on the smartphone, and it can also work offline. We provide the things so that they can take the devices. They don't have to be a medical personnel. It could just a high school personnel who can enter the data on the smartphone or put the number in. And on the other end, the doctor could be in any hospital or primary health center or whosoever are willing to provide the service. We give them training. They only need a smartphone on the other end. The devices and everything is at the village side with these Sahayakars or with these telemedicine operators. Now, this program allows us to remote access through using the internet, or it works on 4G using the cell towers. We can do the screening, just go and get the data. Triage, we have about 300 plus symptoms with automatic algorithm where the yes and no answer actually builds up the history part that doctors usually would want to do doing medical visit. And they take the vitals of the equipment we have given. They also add all the demographic data, their living habits, the diet, activities, etc. So all these things, we are able to do it, which has a tremendous value in analyzing the problems and the solutions. Also, of course, with this and the doctor at the other end, we can do the teleconsult. We give them a small printer, so we can print out the prescriptions and give the reports, and we can also arrange for the follow-up visits. So everything is done using the smartphone and the devices, the hardware that we have donated. Of course, this because the Sahayak builds up all the history and get information, so it saves doctors tremendous time. Doctor only see what is the positive finding. They now have baseline information. We can detect some of the condition like diabetes or high blood pressure, which patients may not be aware. So we can actually diagnose while doing the screening, and we can build up the database. And of course, for doctor, it's an easy because they also have this hack. Now think about it. It will be expensive for the villager, every villager to have smartphone in their hand and internet connectivity and the devices. So what we have created is a one system and multiple user rather than one system and one user. And that brings us, it's like a early days of telephone, we had telephone booth. So people would go there and use the telephone. Of course, now we have, each person has telephone in their pocket. But this is the analogy what this center can do. And of course, when you went to use the telephone, you only put the usage charge, put a little coin or more coins to get the service, the same concept. So this is how this will work. So this heart center, $1,000 donated by WGF. Of course, this donation money some part comes from the directors and the people we donate. We donate that we use to provide these devices and the hardware. Now the operational cost. This is where we say the sustainability and the livelihood. I'm not sure why this keeps on changing. So can you see this slide okay?
Yes, Raj.
Okay, good. then I'll just keep it here because when I put the full screen, it's somehow or other it's not working on my system. So we give this $1,000, buy this equipment. Now this operational cost components, there are three components to it: doctor's fee, telemedicine operators to people that we selected from village, their salary, and cost of technology support and maintenance. It comes out to be, this is the cost. Normally, for the for-profit company, they will charge 250 to 500 rupees for a visit. We are charging only 110 rupees, equal to almost $1.50. That's our operational cost, of which 50 rupees is given to the doctor for that 10 or 15-minute consultation. 30 rupees is given to the salary to the telemedicine operators or Sahayak. And then 30 rupees is goes toward the technology and support fee. Now, if any one of these components, we have, for example, in Anandpur district of Andhra Pradesh, which may not be too far from Chennai, RDT Foundation has 3 hospitals. And these hospitals, they have doctors, they give free service if patient come to them. They have agreed that we'll be happy to give our telemedicine teleconsult to villagers so they don't have to come. They support 6,000 villages. That's the area this RDT Foundation's 3 hospitals support. So we started our first project with 6 sites in Anandpur district serving Chanchu tribe, and they are providing free doctor's visit, so patient don't have to pay that. They have volunteers from the villages, so they don't need this salary. So now that much is less. So patient only pays 30 rupees, and often if they are too poor, we don't charge them. So this is how we generate about 110 rupees. This is our operating cost. Out of this 30 rupees that is given to technology company, they have agreed that they will donate back 10 rupees because 20 rupees is their cost of the personnel who actually go support software updates, maintenance, and everything. So, and this is how we make it not only self-sustaining, but also self-growth funded project. Normally, in today's time, it will cost patient maybe 500 up to 2,000 rupees for one visit outside of their village for the travel as well as out of town stay if they have to stay, and loss of wages. So that's how it is. We are now created a system of providing access to the villagers at their doorstep at a very affordable cost, which can also be further reduced depending on donations or the services that we can retain. That's why I call it a financially self-sustaining project. Now, it is self-funded also because 10 rupees, there may be something in this calculation which is based on my ramp-up analysis. And this number of visits should be 250,000. Be that as it may, but if we have a 1,000 sites, our total investment is about $1 million. We can then generate, it is self-sustaining at 1,000 sites on average. If it is 250 days, and if our projection is based on 10 visits a day, each visit could be completed in about less than 30 minutes, but let's say they do only 10 visits a day. It's based on that. We will generate enough money just from 10 rupees coming back. We already covered doctor's fee. We already covered the salary. We already covered all other overhead. Then we will earn about $350,000 in return every year, which will allow to add another 290 to 300 sites. So that's a multiplier factor, and this is our projection when we come to that. And I'll share you one slide where we stand on that. And obviously, telehealthcare benefits everybody, makes it easy access and convenience, lower cost. We still deliver the same quality care, beneficial for the patient. It helps doctors because they can now do the consultation from the comfort of their office or home, and uh, expand their practice. And also, not only just the medical thing, but screening and monitoring also help detection and management of other diseases. So overall, it has a tremendous beneficial effect in the ecosystem. Project implementation and these are the real pictures that the person, Evolco person, will go to the village. He will screen, work with the local Gram Panchayat. He will screen people who can basically do and perform, and train them to be a Sahayak or telemedicine operator. Then they will give the training just for the doctors as well as for the Sahayak. Then we call it a center. There is no brick and mortars here. It's an Amazon model. The telemedicine device bag and phone is the actually the telemedicine center. Of course, the person can we have put a little sign that this is their center, so patient can come to their home, or they can take the bag and go to the patient home. So this works very well for the villagers, and because the person chosen is the resident of their own village, they are very comfortable talking and in their own language and understanding the cultural aspect of the things, which is very important for healthcare delivery. And the software is in 12 different languages, including Tamil and Marathi and Gujarati and Hindi and all this. So it becomes very easy for them to operate. Of course, once we have these people are ready, we have a health fair for all the villagers before the system is operationalized, and then the things occur. So after doing this is what we have done in last 8 months. We started in November, December during holiday time. We are full functional starting January. So between January and May, we saw about 1,500 patients in those 6 sites and delivered the care. We collected some money for that. Now come COVID second wave in India. We decided that we do not want to charge patient, and we just want to give free service. So during this pandemic, we were very grateful to receive tremendous donation. We had started with our $30,000 budget, which was there from original WGF. We received close to $250,000 to $300,000 donations, and Health Council has used that donation. We have built 300 more sites, to be exact, 324 sites that we have built in last 2 months. The cost we have decreased because instead of full-fledged everything for the COVID treatment, we needed only temperature, a blood pressure, and a pulse ox. So we gave only 3 devices, and instead of 2 kits, 1 male and 1 female, we'll just give 1 set for 1 individual during the COVID, and that's how we have this 350 for each site. We have 300 sites. We already donated $100,000. The goal is 1,000 sites. 1,000 sites which will be fully functional. We need $1 million. So we need about $400,000 to $500,000 from now till 2021. Each site I showed you, which gives you this hardware. In addition to this, there is a dire need for life-saving equipment, oxygen concentrator, generators, BiPAP machine. So we have donated 500 units. I'm sorry, cost of each unit 500. We don't facilitated and donated 470 units. That's the cost. personal hygiene kits through Aadhar Shila, which is a NGO in Delhi, which serves the slums population in Delhi. And they have not only, they have literally nothing. They don't even have shelter. They don't even have food. They don't have, forget about medical care, soap and personal hygiene kits. That's what we spend money and provided that to them. Our goal, we gave 1,000 sites, $25,000. Our goal is to add another 4,000, and so we need this money. And then we supporting the IIT institutes in Kharagpur and other, and in Kanpur and Delhi and Madras, trying to find out a rapid testing for COVID, as well as the manufacturing of the oxygen generators, etc. So supporting the technology solution for which can drive and help the healthcare delivery. And finally, the healthcare education. We haven't done very much, but our plan is to provide COVID testing, vaccination awareness, education by posters, pamphlets, videos, etc. So this is what we would like. So that's our need, how we want to spend. So just to update you, as of last week, we have opened 147 telemedicine sites in Uttar Pradesh, 106 in Bihar, 28 in Maharashtra, 17 in Madhya Pradesh, 12 in Chhattisgarh, 6 in Andhra Pradesh, Anandpur district, and 4 in Gujarat, in Arwali district, total 320. And in last just month, once everything was distributed and given, we have served 4,745 patients. Now, where are we getting the operating cost? Evolco is donating. They're paying doctor of their. There are about 200 doctors on their panel, and they are giving the use of software and services free. So this is how, in just $350 for each center, we have been able to provide service, and will continue to provide service till COVID. Once the COVID threat and COVID comes under control, we will then be going to our self-sustaining operating cost generating model. So this is in nutshell the thing. And I think at the end, obviously, we would ask you the $1 million question, whether 1 million, 1,000, or whatever. We'd like you to be part to change lives of rural India. And we are asking you, could you, by donating any or preferably all time, talent, and treasury, we need you. And this is the appeal. And the appeal could be, it could be a small donation of just $1,000 to create 1 heart centers in your choice village, or multiple of this. And that's the appeal that I can do. And I'll of course ask you to donate, and I'll let the Sushilji take it from there. Thank you, Sushilji. Thank you for listening.
So let's have a discussion now. Okay, what is it